Probably a pleasure to be here. Thank you for having me to moderate this session. And thank you, Liz, for all your work in planning the annual Pain Center conference, as well as running all the organization today. I appreciate it. My name is Mariana Bueno, and I am a neonatal nurse by training, and currently I am an assistant professor at the Lawrence Bloomberg Faculty of Nursing at the University of Toronto. So welcome, everyone. I know we have an audience from all over the world, and this really aligns with our goals for this conference. And welcome to our session, Trainees Rapid Fire Presentations. Today, you will hear about cutting-edge research that is being conducted across the globe and in alignment with our conference theme, Advancing Pediatric Pain Care Equity, Addressing Challenges and Opportunities in Low and Middle Income Countries. These presentations reflect a shared commitment to improving pain care for children, especially in contexts where equity and access remain pressing challenges. We will have each of the presenters using about 6 minutes to share their work. And while our speakers' bios are truly impressive, I will share them with you through the chat. I will be introducing each of them briefly at the start of each presentation so we can keep up with our schedule. Also, if you have any questions or comments, please feel free to add them to the chat, and we'll wrap up with a Q&A session after all the presentations. First up here in my list, I have Dr. Satvika Janarthnam. Dr. Janarthnam is an anesthesiologist and a pediatric anesthesia specialist currently practicing at Apollo Jayanagar Hospital in Bangalore. So welcome, Dr. Janarthnam. I apologize if I'm not pronouncing your name properly. Just correct me if I am wrong. And thank you so much for sharing your work with us. Welcome.
Good afternoon. Today, my topic is Necessity is the Mother of Invention, a preliminary report on pain management in children with chronic pancreatitis in India. So my guide is Dr. Anuradha, who is an associate professor in Indira Gandhi Institute of Child Health. So as we know, the incidence of pancreatitis in children is increasing. Abdominal pain is the hallmark, yet there is still a lack of studies on pediatric pain assessment and relief strategies for pancreatitis in India. And this research hopes to bridge this knowledge gap. In children, pancreatitis is categorized as acute recurrent, and chronic pancreatitis. Acute pancreatitis requires more than 2 of the 3 criteria, that is abdominal pain suggestive of acute pancreatitis, or a serum amylase or lipase level which is greater than 3 times the normal, or imaging findings which are characteristic of acute pancreatitis. Acute recurrent requires greater than 2 episodes of acute pancreatitis plus a complete resolution of pain in between the 2 episodes, or a complete normalization of the amylase and lipase levels. And chronic pancreatitis requires more than 1 of the 3 criteria, that is pain consistent with pancreatic origin or imaging findings, or evidence of exocrine or endocrine pancreatic insufficiency. So the main aims were in order to document the pain patterns in children admitted with pancreatitis in a tertiary pediatric center, and to record the analgesic prescription patterns in children with pancreatitis. The study design was a retrospective cohort study. The source of data was the Acute Pain Services Database and consultant records, case files from the MRD, and the e-hospital database of the institute. The Acute Pain Services Database was analyzed, and those patients who were fitting into the inclusion criteria were selected for the study. The period of study was from September 2021 to December 2024. Those patients who had been diagnosed with acute pancreatitis, acute recurrent, or chronic pancreatitis and were referred to APS for pain management were included. Those patients who had other causes of abdominal pain or who were treated on an outpatient basis were excluded. Statistical analysis was done by the SPSS software, Descriptive and inferential statistics were analyzed, and categorical data were expressed in numbers and percentages, and a p-value less than 0.05 was considered statistically significant. So in results, we have a majority of the patients from 10 to 12 and 13 to 15 years of age group. About 60% of the patients were female, 40% male, and almost an equal distribution of patients with a diagnosis of acute, recurrent, and chronic pancreatitis. Mean weight was around 29.7 grams and the length of stay was about 12.3 days. Most of the patients had an idiopathic cause, while the other risk factors, about 15%, had pancreatic divisum. Other risk factors included infections like mumps or a drug-induced, like patients who were on retroviral medications or on carbamazepine, CKD, cholelithiasis, or a chronic liver disease, diabetes type 1, choledochal cyst, or trauma. So most of them presented with a dull aching or a colicky type of pain, some of them with a squeezing, spasmodic, or a pricking pain. Associated symptoms like nausea, vomiting, fever, constipation, and a few with weight loss. The pain aggravated on having food in 16 patients. It relieved on skipping meals for 8 patients and in crouch positioning for 5 patients. It radiated to the back in 11 patients. The initial numeric rating scale, that is, how we rate the pain, was high in all the patients. So the initial NRS, the mean, was around 7.4. which, after treatment with medications at 24 hours, it reduced to 3.1 and further reduced to about 1.1 at 48 hours. Now, on dividing this into the 3 categories, we saw that the pain initial NRS was highest for patients with acute recurrent. So they had an NRS of about 8, which further reduced to 3.5 and 1.2 after treatment. This was followed by patients with chronic pancreatitis who had an initial NRS of 7.3, which reduced after 24 and 48 hours, and subsequently. And for acute pancreatitis, they had an initial NRS of 7, which further reduced similarly. So this reduction in NRS can be seen in this graph, and we can see that the reduction in NRS is clinically significant in the graph. So when we see the minimum clinically significant difference between the initial NRS and the NRS at 24 hours, there was a mean difference of 2. The p-value was less than 0.01, and hence the difference between the initial NRS and the NRS at 24 hours was proved to be clinically significant. Similarly, the NRS at 24 hours and NRS at 48 hours, the mean difference was again 2. The p-value was less than 0.01, and hence the difference between the NRS values at 24 and 48 hours was again clinically significant. Now coming to the analgesic usage. In acute pancreatitis, mainly opioids, NSAIDs, and paracetamol was used, whereas in acute recurrent and chronic pancreatitis, a neuropathic agent like gabapentin was also added. Some patients also had to have invasive procedures like sphincterotomy, stenting, epidural catheter placement, laparotomy, or cystogastrostomy, or an LPJ. Now, when we come to the morphine milliequivalence, we can see that the main MME was scattered around 0.4 to 0.6 in most of the patients. When we calculated the MME at 24 hours, in our study, it was 0.57 when compared to a study by Gorbanova, who noted an MME 24 of 0.59. The MME differences between AP, ARP, and CP was not clinically significant. So, coming to the discussion, in our study, the pain pattern in children with pancreatitis is similar to the available literature. Initial NRS scores were comparable in all the 3 groups, reflecting the severity of pain experienced by these patients. Analgesic usage varied significantly compared to the existing literature, with increased reliance on multimodal analgesia, that is, the usage of opioids, paracetamol, and NSAIDs in 87.5% of the patients. The remaining received only NSAIDs and paracetamol. A few required epidural analgesia. And endoscopic procedures and drainage procedures were done in order to decrease the incidence of acute flare-ups. Most studies in pediatric acute pancreatitis have used only opioids, and a few have used NSAIDs alone, with multimodal analgesia rarely being used. In our study, multimodal analgesia was noted to be efficacious in reducing the NRS scores significantly in all groups of patients. As told before, the MME24 in our study was 0.57 when compared to a study by Gorbanova, who noted an MME24 of 0.59. The length of stay was independent of the type of analgesia used in our study. The limitations were that this was a retrospective chart review, so there may have been missing data or incomplete data. The data was not analyzed on the usage of analgesics after discharge and during follow-up. Unidimensional pain scores were used with no record on the effect of pain on the quality of life indicators. So this was the first study from a Southeast Asian country documenting the pain patterns and analgesic usage in children with pancreatitis. Multimodal analgesia was used exclusively in all patients with good efficacy, but more research is required in order to corroborate this data. Tramadol is still being used for acute pain in children despite FDA black box warning reflecting global disparity in opioid drug availability and rigid regulatory concerns. So to conclude, pediatric pancreatitis is a disease with a wide spectrum, but the management can be standardized. Multimodal pain management, which included paracetamol, tramadol, and NSAIDs, were prescribed for children with pancreatitis in our institute and yielded good pain control with nil side effects. Longitudinal studies are needed to better understand the role of risk factors in disease progression and burden, as well as randomized control trials in order to identify the best treatment options. So these are my references. Thank you.
Thank you very much, Dr. Janarthnam, for this great presentation, very insightful. I invite now Dr. Sharadha Manjunath, Assistant Professor in the Department of Anesthesia at Indira Gandhi Institute of Child Health in Bengaluru, India as well. Welcome, Dr. Manjunath.
Yeah. Hi all, I'm Dr. Sharadha. I work as Assistant Professor in Anesthesiology at Indira Gandhi Institute of Child Health, Bangalore. Procedural pain, even something as simple as a needle prick, can be distressful and painful for a child. So we wanted to see, by introducing non-pharmacological, easy to use equipment in the regular care of children for venipuncture, we can bring down the anxiety and the pain associated with the needle prick procedures. So I'll be presenting on the clinical efficacy of Buzzy device in decreasing pain in children undergoing venipuncture in a pediatric hospital setting in India. So our learning objectives are threefold today. Firstly, to understand the rationale for using the Buzzy device to reduce procedural pain in children. And secondly, to describe the design and key findings of our pilot study, which was a case control study. And finally, to appreciate the clinical implications and feasibility of using the Buzzy in routine pediatric anesthesia practice. Needle prick procedures are a part of hospital experiences. They are essential for various treatments and diagnosis, and they are also reported to be the worst experienced pain during the child's hospital stay. And the proportion of severe pain is reported to be 70% in case of children who are hospitalized, and because of which they can have short-term and long-term consequences. Short-term consequences can be as simple as non-cooperation for the given procedure, and long-term consequences can be behavioral and psychological disturbances, lack of trust between the nurses, doctors with the children, and refusal for future hospital admissions. And to improve the quality of the healthcare, we need to address this pain and anxiety associated with the minor procedures. So in this study, we have used a device called Buzzy. It combines both cold and vibration sensation, and it works by leveraging gate control theory of pain, and also by leveraging descending noxious inhibitory control. I'll come back to this device later. So basically, to decrease the pain and fear associated with the needle prick procedures, we have non-pharmacological methods and pharmacological methods. Non-pharmacological methods may be parental presence, breastfeeding, sucrose, or non-nutritive sucking, swaddling, and rocking. These methods have been found very helpful in case of neonates and infants. Whereas distraction methods like music, toys, balloons, clown therapy, distraction cards, and sometimes smartphones with cartoons, comics, and videos have been found useful in older children. Coming to the pharmacological methods, the options are very limited. One of the examples is eutectic mixture of local anesthetic, which is a mixture of lignocaine with prilocaine. Other options are liposomal lignocaine and emethicaine local anesthetic. But all these options are time consuming and sometimes may be impractical in case of high input and resource limited setting like ours. So coming to the device per se, it is a child-friendly looking B-shaped vibrating case. It has a motor which vibrates at 100 hertz. It also has an optional ice pack. It leverages the gate control theory of pain. It stimulates larger nerve fibers which are myelinated like A beta and A delta fibers with a vibration, and smaller nerve fibers like C fibers with the cold sensation. While using this device, the device is directly placed where the venipuncture is planned at least 30 seconds before the procedure, and just before the prick the device is moved a little away and above from the site of the procedure, and the procedure is carried out as usual. It uses natural pain relief by confusing body's own nerves and distracts away from the needle pain. So why we particularly used this device? This is an original article published by a hospital in Taiwan by Cho et al. It also studied the effectiveness of Buzzy device in pain relief for intravenous injection. As mentioned here in the first line, most clinical institutions do not have time to instruct and console the patients, which could reduce the needle pain. We face exactly this problem in our hospital as well. The nurse to patient ratio may be as high as 20:1. One nurse will take care of at least 20 patients, and majority of their work involves giving intravenous drugs and monitoring, etc. Consoling the patient, opting for a distraction method to provide good care for venipuncture sometimes may not be practical in our case. So we wanted to introduce a device which is non-pharmacological. It has less preparation time and easy to use and mostly reusable. So we chose this equipment. And as mentioned here, most of the children and parents wished for an effective pain relief measure. So exactly, we wanted to plan for that. Coming to the objectives of the study, primary objective was to study the efficacy of the Buzzy system between the age group of 3 to 12 years. And secondary objectives were to compare the time taken to cannulate between the Buzzy group and non-Buzzy group, and to compare the number of attempts, and also to compare the anxiety scores between the groups. To document the pain, we used Wong-Baker FACES scale, and to document the fear, we used children's fear scale. And random sequence, coming to the methodology, random sequence allocation was done, and 30 children were chosen between 3 to 12 years age group. They underwent venipuncture or cannulation either using Buzzy or without it, behind the closed doors with a parent or caregiver one at a time. The pain and anxiety using validated scores and number of attempts and time taken for the procedure was recorded. So these are the results of our study. Age, gender, and site were comparable as the p-values were more than 0.05. They were clinically non-significant, and thus proves that the comparison was fair between the groups. Coming to the results, the pain scale was the mean pain scale was 2.86 in case of control and 1.6 in case of children case group. The p-value was 0.01, which was less than 0.05. Which is clinically significant. And coming to the fear scale, in control group it was 2.8, and in case group it was 2.06. The p-value was 0.013, which is again clinically significant. And number of attempts was 2.13 in case of control group and 1.46 in case of case, and the p-value was 0.033, which was again clinically significant. As shown here in the pie chart, the children who complained of moderate pain was 60% in case of the Buzzy group, whereas in control group, the children who complained of moderate pain was 73%. In case group, that is Buzzy group, the mild pain, the children who complained of mild pain was 40%, whereas in control group, the children who complained of severe pain was 26.7%. So to summarize the results of our study, 26.7% of the children who underwent venipuncture or IV cannulation in control group with routine hospital care experienced severe pain. P-value was 0.01. 40% of children in Buzzy group experienced mild pain. Fear of needle prick after introducing the device was slightly lower in cases compared to control group, and slightly fewer attempts when the device was used. We also compared the time taken for the successful procedure. P-value was 0.85, which was non-significant. Coming to the discussion, as I mentioned before, venipuncture and needle prick procedures can cause significant pain and fear in hospitalized children, but the average number of attempts for intravenous insertion was 4.2, and restraining remains the last resort. And as mentioned in the earlier session today by Dr. Mike, was told that the parents are provided with the EMBLA cream and they are instructed to apply the EMBLA cream before they come to the hospital. But sometimes that kind of instruction may not be practical in our kind of setup, where the parents are not so educated to understand the consequences or the gravity of the instructions. Sometimes they don't even comply with the NPO orders. So in that kind of situation, it might be very difficult to follow that kind of protocol. So sometimes restraining becomes the only last resort for carrying out these kind of needle prick procedures. So suboptimal pain management may be because of lack of knowledge, time constraints, and lack of resources in our kind of setup. So to conclude, Buzzy significantly reduced the pain and anxiety during venipuncture. Fewer attempts were required, improving procedural success, and it was feasible and safe for routine pediatric care. There are some limitations in our study as well. It was not applicable for children with cognitive impairment or very critical disease. And it was a single center study, and we could not determine the differences in the demographic. In future, carrying out multi-center study might be more useful and provides better data. Intra-group comparison between the different age groups among children who participated in the study could not be done, as preschool children may react to needles very differently irrespective of the interventions. So take-home message. The device is user-friendly, has child-friendly aesthetic. It has short preparation time and is well accepted by the children and caregivers. In busy hospitals, especially in middle-income countries like India, where resources and time safety are limited, Buzzy offers a practical solution. When options like topical anesthetics like EMLA are time-consuming and distraction alone is insufficient, even smaller interventions like Buzzy makes a big difference. These are my references. Thank you.
Thank you. Thank you so much, Dr. Manjunath, for this great presentation as well. We appreciate you sharing it with us. So next in line is Dr. Josep Roman-Juan, who's a postdoctoral fellow at the University of Manchester and the current IASP John Bonica Trainee Fellow. So welcome, Dr. Roman-Juan. We are looking forward to hearing from you.
So good afternoon, everyone. Thank you again, Mariana, for the kind words and the introduction. Today, I'll be sharing with you the very preliminary findings from the study we are conducting, which aims to examine how national level poverty shapes chronic pain and chronic pain-related socioeconomic disparities in adolescents living in middle-income countries. As you all know, chronic pain, which is defined as pain lasting at least for 3 months, is an urgent public health concern among youth, as it affects the mental health, the daily function, and the long-term health outcomes of this population. Research has shown that globally, about 1 in 5 children and adolescents experience some sort of chronic pain. However, this burden is not evenly distributed. Adolescents living or adolescents coming from lower socioeconomic backgrounds are disproportionately impacted compared to those coming from higher socioeconomic backgrounds, and those living in lower income countries report significantly higher prevalence rates of chronic pain compared to those living in higher income countries. Emerging evidence suggests that the burden of disability from pain will continue to increase in low and middle income countries in the upcoming decades. And although these countries represent over 4/5 of the world's population, we know remarkably little about the macro level social and economic factors that may shape the vulnerability to chronic pain in this particular context. One macro level factor that has received almost no attention at all is the national level poverty. Structural poverty limits access to healthcare, quality education, safe environments, and nutritious food, while increasing exposure to chronic stress and adversities. And as we know, these are all mechanisms linked to pain development and persistence. However, as I was mentioning, to our knowledge, there are no studies examining the association between national level poverty and chronic pain in adolescents living in low and middle income countries. So our study asked, or the aims of our study were to determine whether national level poverty contributes to the prevalence of chronic pain among adolescents living, in this case, in middle income countries, and to determine whether national level poverty contributes to chronic pain related socioeconomic disparities in adolescents living in middle income countries. And provided previous research, we hypothesized that higher levels of poverty would increase the likelihood of reporting chronic pain in adolescents living in these middle income countries. And the second hypothesis was that chronic pain related socioeconomic disparities would be wider at higher levels of national level poverty. To address these aims, we used the 2018 health behavior in school-age children data coming from this study conducted by the WHO, which is an international cross-sectional school-based survey conducted essentially in Europe and North America. This study includes nationally representative samples, adolescent boys and girls aged 11, 13, and 15, and aims to monitor the health and well-being of adolescents across the regions I mentioned. For the purposes of the current study, we focused specifically in countries that in 2018 were considered as low or middle income, using the criteria of the World Bank data. And therefore, the studies that you can see on the screen below on the slide, the studies we included were Ukraine and Moldova as lower middle income countries, and Armenia, Bulgaria, Georgia, Kazakhstan, North Macedonia, Romania, Russia, Serbia, and Turkey as upper middle income countries. And considering all these countries together, the final sample size that we included comprised over 50,000 adolescents from these 12 countries. In this case, chronic pain was assessed using the HBSC symptom checklist and was considered present if participants reported some sort of pain over the past 6 months. The family socioeconomic status was measured using the third version of the family affluence scale that included several items, such as family car ownership, having their own bedroom or computer, and so on. We took the scores and we summed these scores of the items that the participants responded, and then converted these scores into relative ranks within each country, categorizing adolescents into 2 affluent groups, the low or the lowest 20%, and the medium and the high that comprised 80% of the population. In this case, national level poverty measure came from the World Bank. We used the poverty headcount ratio, which represents the proportion of population living below an internationally standardized poverty threshold. For lower middle income countries that are Ukraine and Moldova, this poverty ratio was established at $4.20 per person per day, and for upper middle income countries, it was established at $8.30 per day. And to address the study aims, we ran mixed effects logistic regression models to account for clustering at the schools and the country levels and applying the sample weights as the survey requires. And we also tested interaction effects to examine whether the poverty effects differed by the socioeconomic position of the participants. These are the main findings of the study. If you require the descriptive statistics, I am more than happy to share them with you. But these slides essentially, what essentially is showing us is that girls and adolescents from low socioeconomic backgrounds were more likely to report chronic pain than boys and adolescents from higher socioeconomic backgrounds. And there were no associations between the age of the participants and chronic pain. And regarding our key predictor, that is national level poverty, we saw that there was a significant positive association between poverty and chronic pain, meaning that adolescents living in countries with higher poverty, the rates of chronic pain were significantly higher or were more likely to report chronic pain. Importantly, as you can see on the screen highlighted in red, we also identified a significant interaction effect between the socioeconomic position of the participants and national level poverty, which, according to the graph, suggests that chronic pain disparities by the family socioeconomic position narrowed as the national poverty increased, or in other words, as poverty becomes more widespread in a country, the gap in chronic pain between low and middle high affluent groups shrinks. As per the implications and the implications and the discussion or the conclusion of the study, our study provides the first evidence that national level poverty is associated with chronic pain among adolescents in middle income countries. These findings highlight highlight the importance of considering macroeconomic and structural factors, not only individual level characteristics, when addressing chronic pain in youth. The findings suggest that poverty functions as a broad structural risk factor for chronic pain, consistent with the literature linking material hardship to stress, reduced resources, and cumulative adversities. The narrowing gaps at higher poverty levels may indicate that when poverty becomes pervasive, the disadvantage affects nearly everyone, diminishing socioeconomic differentiation. If replicated, the findings would support the need for prevention efforts, prioritizing structurally vulnerable groups, not only individual level risk profiles. They would also encourage, again, if replicated, they would encourage policies addressing economic inequality, which may have downstream benefits for youth pain outcomes, and would require universal supports where deprivation is widespread, not only for those from lower socioeconomic backgrounds. And this is essentially the preliminary findings. Thank you.
Amazing. Thank you so much. Very inspiring work. And up next, I welcome Dr. Mwemezi Kaino, who is an anesthesiologist at the Cure Children's Hospital of Kenya. Welcome, Dr. Kaino, and thanks for being with us today.
Thank you very much. I'm Dr. Kaino from Cure Kenya. I have established a pain database here, which is very unique in this part of the world. And I'll be sharing why did I do that, and also the challenges that I faced in doing so. This is the hospital where I work at. It's Cure International Hospital in Kenya, a highly specialized pediatric orthopedic hospital. It's one of 7 hospitals in Africa that are owned by Cure International Organization, which is headquartered in Michigan, USA. Cure Kenya has 60 beds, 4 operating rooms, and we do about 3,000 procedures per year. We have an electronic medical records, but it doesn't cover pain and anesthesia, and that poses some challenges in data collection. Overall, in the world, I think we know that OR performance is assessed using productivity, efficiency, and quality. But in many parts of Africa, only productivity is used to measure OR performance, which is number of cases per day, per year. So that's why I wanted to measure the quality of outcomes in this part of the world. But other reasons include what we hear from patients. For example, a patient says, if I had known about the pain I would experience after surgery, I would have chosen to live with my deformity instead. So this just shows that cure is worse than the condition. Other reasons include studies like this that was looking at pediatric chronic prevalence in low middle income countries. This was a systematic review that was done in 2022. And if you can look down here, low middle income countries constitute to about over 60% of the world countries and over 80% of the world population, which is about more than 90% of the children in the world. But in 10 years, this study managed to identify only under 3,000 articles. They reviewed 70 and only 20 made it to analysis. And if you can look here at the occurrence of acute pain, the wide range in the occurrence of acute pain, you can tell that there is very little data that is collected. And this data has very poor quality. The poor quality in terms of correctness, completeness, and the custody, the chain of custody of the research materials. Most of the times, you will find studies that have used the wrong variables, and then they use wrong tools to investigate those variables. There is heterogeneity in methodology, variables, and tools. Therefore, it becomes difficult to compare and contrast results from different studies, which are also very scant. The importance of databases, I think, very familiar to all of us. Enable tracking of pain management practices, support evidence-based protocol, facilitate research and resource allocation, promote accountability and quality improvement, and overall, they improve patient outcomes. You cannot improve what you don't measure. So data has become very important, so much so that the creation of it has exploded in the past 2 decades, reaching up to 1,500% in the decade that ended in 2025. 70% of GDP digitized at a staggering near $7 trillion. Data has become the new oil and is concentrated in few countries. If you look at healthcare data poverty in low-middle-income countries, look at where Spain is comparing to the United States. And now if Spain is here, where will Kenya and Tanzania be? So this further illustrates the importance of actually trying to create data in this part of the world. Equally important is considering the fact that about 90% of the global child population live in the sub-Saharan, in global south, in the global south. Okay, Nigeria, for example, has 2 million people and 300 ethnic groups. Now, this, I think, would have contributed to the diversity of the pain that would have started in the world. Overall, over 80% of data is unstructured in the sub-Saharan Africa and in low-middle-income countries, and it is very expensive to structure this data. So it is collected, but it all just contributes into the data graveyard, the wastelands of the data. And data drought in this part of the world leads to ineffective data utilization in healthcare and underrepresentation of large populations that have significant socioeconomic diversity. So that's why this is the database that I have generated here, I've created here in Kenya at my hospital. And these are the data points pre-op, intra-op, PACU, post-op day 1, day 2, post-op 3 months and 6 months. And these are some of the variables that we are studying here at Cure Kenya. It's fairly comprehensive. So I'll talk about maybe the challenges, and we can discuss the solutions during the discussions later on. And I've separated them into space, staff, and systems. And regarding space, I think the challenges is that these institutions were built without considering research as part of an integral. They did not integrate research in the infrastructure as they were building it. So we lack space for housing the research materials and just having offices for meetings or for ideation or for whatever. Internet servers and electricity are usually not very stable, and therefore you may not have a very good space, a safe space to store your data. Considering staff, the cabinets, if you look at this cabinet here in the picture, it took me about 3 months to get it, leave alone the space where it is sitting. So the person you've seen in this previous slide here is a medical student from University of Amsterdam who came here on external rotation, and he was the project coordinator for this database, because the hospital asked me where you're going to get time to coordinate all these activities, and they questioned my clinical availability. So I had to get someone to actually do it, to maintain that correctness, completeness, and make sure that the data, the research materials are kept in order. It's very difficult to get people who can help you with IT and statistics, or create a database, or make sure it is running safely and efficiently. The systems, if you look at the hospital factors, just the guidelines may be a problem just in themselves, because you will have one anesthesiologist, for example, preferring using ketamine exclusively. Another one gives a lot of opioids. Another one does blocks. So comparing pain outcomes from patients like that becomes a big challenge. So things are not standardized, but also we don't have protected time to do this. So I do this at night and on weekends, my private time. Developing a protocol was in particular very challenging, because I didn't know what variables to include. There were so many variables out there to study pain, so I didn't know which ones to include. And after I got a set of variables that I wanted to include, each variable had about 10 tools that you can use to, and that was really a nightmare for me. So it took me a while to come and decide which tools should I use for which variables. And I think I got in touch with Professor Jennifer, and she helped me a lot in that. Getting IRBs, especially if you're doing a multi-center or multinational study in this part of the world, is very challenging. And budgeting, we still don't have access to grants that can support this kind of studies. And I'm doing this out of pocket and in-kind contributions. In conclusion, there is a pressing need to address uncharted pain in this part of the world. And we need to develop and harmonize frameworks for research and practice in pain management, so that people who are not experts in pain can actually also contribute by doing research in pain. We need to integrate pain management content into the educational curricula, because most of the undergraduate and resident curriculum do not include pain management. And we need to encourage funders to support initiatives in the Global South, like the one that we are doing here. Thank you. We'll take part more in the discussions. Should stop here.
Thank you. Thank you very much, Dr. Kaino. Very impressive work, especially with the low resources and your drive to really put this out there and up and going. So congratulations on that. Very impressive. And we can talk more about this during the Q&A session. I want to invite now our last trainee of the day, Bukola Mary Ibitoye. Bukola is a doctoral candidate at the School of Nursing of the University of British Columbia. And I am welcoming you, Bukola, to share your work with us. Thanks for joining.
Thank you for the opportunity to share my research, and thanks for the introduction, Mariana. I'm Bukola, and I'm here today to give a presentation on a research study that is part of my PhD. And the title of my presentation is Understanding Non-Pharmacological Pain Management in Nigerian Adolescents with Sickle Cell Crisis, Healthcare Providers' Experiences. So this research that I'm going to present is part of a larger project called the Burisavi Project. And the Burisavi Project is aimed at developing a patient-oriented, expert-informed pain toolkit to introduce Nigerian adolescents to safe and evidence-based non-pharmacological interventions that they can use whenever they're experiencing sickle cell crisis pain. So the study I'm going to present is the phase 3 of this multi-phased project. So I'm going to give a bit of a background into sickle cell crisis. Sickle cell crisis, they are recurrent, unpredictable episodes of moderate to severe acute pain in people living with sickle cell disease. Sickle cell disease itself is an inherited blood disorder that is affecting millions of people globally, especially people living in sub-Saharan Africa. Sickle cell crisis pain is a leading cause of hospitalization in adolescents living with this disease, and experts globally recommend that medications such as opioids and non-pharmacological interventions are used in managing sickle cell crisis pain. However, based on the findings from prior work in the Burisavi project, we found that interventions like massage and heat applications are commonly used at home, but there's limited use in hospitals. So this led to the question of what is driving this gap between home use and hospital use of NPIs. So I conducted a qualitative study that aimed at exploring healthcare providers' experiences using and recommending NPIs for adolescents who are experiencing sickle cell crisis pain. We targeted nurses and physicians who provide direct care to this population whenever they have sickle cell crisis pain. We recruited 9 physicians and 5 nurses and analyzed the data using constant comparison analysis. 5 themes were identified in the data, and I'm gonna give a brief explanation of each of these themes shortly. The first one is perception. So this theme describes participants' impression about non-pharmacological interventions. Now, most physicians that I interviewed believe that patients came to the hospital for medical treatment and not to receive non-pharmacological interventions. As a result, these interventions should be used at home and not in the hospital. One physician particularly stated that NPIs would only be effective in those faking their pain. Now, nurses and a few physicians believe that NPIs can be effective for providing temporary pain relief for people experiencing sickle cell crisis pain, and it could also help with reducing opioid consumption. The second theme is the safety and risk of NPIs. So this theme describes NPIs opposed by healthcare providers. Many participants oppose the use of interventions like herbal concoctions, body scarification, or seeking intervention from traditional medicine men. They reported that these interventions were commonly used by adolescents living in rural areas, and several of them cited instances where these interventions led to severe complications like sepsis and even death in some cases. The third theme is recommended NPIs. This theme describes healthcare providers' use of NPIs in their practice. So nurses reported actively implementing NPIs in managing sickle cell crisis pain, whereas physicians were generally more focused on the pharmacological management of the crisis. So nurses reported that they used NPIs like heat application, massage, and a few physicians indicated that they also use or recommend interventions like cognitive behavioral therapy and using cold compresses. Both nurses and physicians supported the use of prayer, fluid intake, and also the use of distraction. The fourth theme is really about NPI education. So with this theme, the participants acknowledged the need for educational resources, particularly evidence-based NPIs, for the management of sickle cell crisis pain. They were generally interested in accessing these resources to improve the ability to manage this condition. Now, from the data, I identified information sources that participants often accessed whenever they are seeking information on sickle cell disease. And some of these sources include like going to PubMed, Medscape, the WHO websites. And also participants suggested various dissemination avenues, including existing WhatsApp groups for nurses and physicians, and also collaborating with regulatory bodies for nurses and physicians in Nigeria, and collaborating with academic institutions to incorporate some of these educational resources into the nursing and medical curriculum. The last theme is about influencing factors for NPI implementation in hospital settings. So with this theme, participants reported resources available in their hospital, for instance, televisions, and several barriers were also highlighted. And I've categorized this into 4 main categories. So the first is institutional barriers, such as the lack of resources. And then we have clinician-related barriers, like the lack of research evidence supporting the effectiveness of many non-pharmacological interventions. And due to this lack of evidence, clinicians were unwilling to implement them in their clinical practice. And patients-related barriers like the urgent need for pain relief. So when the participants reported that when adolescents come in for treatments and they're in a lot of pain, there's no time to implement NPIs. The focus is to administer medications to give them relief as quickly as possible. Then we have NPI-related barriers. And this one was specifically about the limited effectiveness of some non-pharmacological interventions. So what are the implications of this finding? So one, it's really highlighted the need for education on NPIs for healthcare providers in Nigeria. As you note from some of the findings I presented, there are misconceptions about the role of NPIs in the management of sickle cell crisis pain. One, there's also a need for more research evidence on the safety and effectiveness of NPIs. And there's a need for collaborations between multiple sectors like the government, health authorities, and non-governmental organizations to address many of the barriers that were identified in these studies. And when thinking about the implications of this finding to the Burizavi project specifically, it has helped in identifying the NPIs that are opposed and recommended by healthcare providers, and also the influencing factors for NPI implementation in hospitals. And the key one is the dissemination avenues for disseminating information on these interventions for healthcare providers in the Nigerian context. In conclusion, there are critical gaps in adolescent sickle cell crisis pain management in Nigeria, and persistent challenges continue to undermine the effective implementation of these interventions. There's a need to strengthen providers' education and also advance research within the Nigerian context to identify safe and evidence-based interventions to improve pain management for adolescents living with this chronic condition. I'd like to acknowledge my supervisory committee and the funding that I've received that supported this research, and the Sickle Cell Foundation partners that have supported the Burizavi project all along. Thank you so much.
Thank you, Bukola. Excellent presentation as well. Great work from everyone. I see here on the chat, we already have a question from Jen Stinson, and I invite you, everyone in the audience, if you have any questions or comments, please share with us. We still have a few minutes to chat. So Jen asks, I would be interested in hearing what was the most challenging part of your research in LMII settings and how you overcame that challenge, or which advice you would have to researchers or clinicians wanting to do pain research in these settings. I don't want to put anyone in the spot, but Dr. Kaino said he would elaborate on challenges, and I was curious about hearing on that.
Yeah, so So whenever you want to start such an intervention in a hospital or in any healthcare sector, I think you have to look at the 4 S's as described by Paul Farmer: space, staff, and systems. So you have to address all of them if the project is to be successful. And I think the main challenge here is number 1, education. We are not very well educated regarding pain. We don't have good coverage during medical school and during residency. And then that is compounded by lack of mentorship after you graduate and start practicing. Mentors during practice, but also in research. And therefore, when you want to embark into research and study something, or you are forced to do that because you really want to know what are the outcomes of patients, I don't like doing things without measuring the outcome of it. So that really drove me into this. I want to know the result of my labor, my effort, my service to these people. So now the lack of knowledge in this area starts kicking in when you want to do this research. You don't know whether what you're doing is comprehensive enough. You don't know what should be included, what variables should be included in the protocol that you're writing. You don't know what tools to use, what tools are standard to use. And then, you know, I did some literature review, and you find like there are 10 tools for each variable, and you don't know which tool to take, okay? Most of them are validated, most of them are for that appropriate age group, but now you don't know which one is standard, and you don't want to do something, and then 6 months later on, Jennifer Stinson comes and say, oh, if you had, you know, if we had met before, if you had told me about this before, if, you know, you've done a very big job, a lot of effort, but, you know, it's not adding up to anything. So I wanted to be sure that I was doing the right thing from the beginning, and it was very difficult. You know, contacting the authors from all the articles that you read, some will respond 2 weeks later on, giving you an appointment 2 weeks ahead. So that's a month already. Some will not respond at all. You contact them via email and call them. And if they're from the Netherlands, you get a Dutch colleague maybe to do that, and still they won't respond. And it becomes very frustrating. And I think at some point it was like, maybe I should just focus on clinical care and leave research alone. So I think that was the major challenge. But the second major challenge is lack of time, because we are a small hospital here, but it's only surgical. We do pediatric orthopedics only, and we are doing 3,000 procedures per year. And I'm the only anesthesiologist. So I supervise 5 nurses in 4 operating rooms, and I don't have protected time for research. So I do all of this just in my spare time on weekends or at night. Right now it's 11 p.m. Yeah. And I had a full day of 12 hours working in the OR. Yeah, so those are the big challenges, I think. But also you have lack of funding. Our institutions here do not budget for research. So you're not getting any money for the iPads that you're going to use to collect data, or for even printing, or even papers to print. I'm lucky that my hospital allowed me to use the printers and the papers. And then comes the bigger, you know, with the budgeting, like personnel, who is going to collect that data? And now that can lead into very poor quality data, okay? So the solutions, what I did here is that I'm very strong in regional anesthesia, and it is trending now. Regional anesthesia is trending in East Africa. So a lot of residents and fellows apply to come to my hospital to do to study regional anesthesia, to learn regional anesthesia so that I can teach them. And I'll get a resident. So I have residents lined up in the whole year. I will assign resident a room, an operating room, and then I freed a nurse anesthetist and trained her to become my research assistant so that she can collect data for me. So I had that permanent nurse anesthetist to collect data for me. And that room was throughout the year covered by residents who are rotating here at Cure. And then the hospital asked me, if you are to do this big project, we question your availability in the clinical space, something that we've employed you for. We didn't employ you here to come and do research. So I had to talk to my supervisors in the Netherlands, and they say, oh, maybe we can get some medical students. So these were final year medical students who were interested in research. So they came here and stayed for 6 months, and I trained them to become research coordinator. So they were ensuring that the data was correctly collected, was complete, and there was a good chain of custody of the research materials, timely uploading of the research data into the database. The database was developed by my previous students who have now specialized in data science at Duke University, and they are doing their fellowship in implementation science. So I requested them, then they agreed. They helped me to develop the database on a REDCap. This is a REDCap that is managed by my organization in Michigan, and therefore it is under the security umbrella of the organization. It's called the Z-Scaler. So the security is very good. That's where all the emails and the electronic medical records of the hospitals. So yeah, this is how I just would try to move around and cover for this and that. So I didn't pay these people, although data. So we've already collected about data on acute pain from about 412 patients. And now we've stopped collecting data on acute pain. We are continuing to follow up this cohort and collect data on chronic pain, which is becoming a big challenge because of the follow-up. We have to follow them in the villages. And when they come to our mobile clinics to meet with them and collect this data. So the attrition rate is kind of increasing with chronic pain data collection. I don't know if I've touched everything, but just lack of ideation space, just lack of it. It's very noisy. Everywhere you go, it's just very noisy. There's no place where you can sit and just think, and hear your own thoughts. There's no ideation space. There's no place where you can keep the cabinet and all the files in a safe, secured office. All of that is a very big process that you have to follow and wait for 3-6 months to get it. So all of these are things that are very prohibitive in doing research in this part of the world. When I was preparing this presentation, I kind of reached out to a lot of my friends in this part of the world and asked them if they have databases like this and what challenges did they face in developing such databases. And to my surprise, really, there were kind of none. They are non-existent in this part of the world, and these are the common factors, limiting factors. Thank you.
Thank you. Thank you very much for sharing, Dr. Kaino. I am sure this is an inspiring work, and it gives the audience an idea of all the challenges and hurdles that researchers and clinicians in lower resource settings face to conduct their work, things that people here in Canada or in other high-income countries or areas in the world would never imagine to face while conducting their research. And I also wanted to point out that the pediatric pain world is always very collaborative and very welcoming. So I hope you can continue to build these relationships and find support and find people to work with. I always feel collaboration is the way to go and the way to overcome these challenges and to bring equity into our lives, into our realities. So with that, I want to thank the 6 of you once again. All those presentations were brilliant on their own ways, very inspiring, and I am sure you will lead the way into making improvements in clinical practice, in policy, and in future research. So congratulations again, and thanks for sharing your work with us. Thanks for everyone who stick to the end with us.